I take pride in inviting Dr. Krishna Prasad Kudlu sir, founder and medical director of Prasad Netralaya, whose entrepreneurial vision, clinical expertise, and commitment to social service has transformed eye care in Karnataka. From the first government hospital ophthalmic unit in Udupi to a multi-city super specialty network, his initiatives include training young ophthalmologists, establishing an eye bank, and leading state-level vision programs. I take pride in having sir to deliver the masterclass on Phakic IOLs. Over to you, sir. So there's a small technical glitch. Please wait, sir.
I can hear.
Yes, sir. Please proceed, sir.
Yeah, I thank my dear brother Madhu Uddaraj for giving me this wonderful opportunity. I am feeling so bad that I would have been a part of the in-presence meeting, but due to unavoidable circumstances, I have to log in through online. In fact, it's a great pleasure. I think the superstar of Andhra Ophthalmological Society, Madhu, I think he has done a tremendous job. I had a great opportunity to visit his hospital. I did live surgery way back, I think around 3 years before. It's again, I'll be soon visiting his hospital as soon as possible. So I am sharing my, can you able to see my presentation? Can you see my presentation?
Yes, sir. Go ahead, sir. Thank you.
Yeah. Thank you, Madhu. I think kind words. I think Madhu wanted me to talk on Phakic IOL. I think my dear sister Madhu is also here. She is one of my classmates, sister, Dr. Harish Rao's sister Madhu is also originally from Mangalore. So, respected chairperson and the entire team of Madhu's hospital, it did really, I'm missing you all. So, I'll be talking about my experience with IOL Phakic IOL. So actually I'm consultant to biotech. Probably we are the first person who did a lot of work on this particular lenses. So we all know that what and all the patient, the LASIK may not be possible in some of the condition like high and moderate myopia, in patient with very severe dry eyes, patient with very extreme steep and flat corneas, patient with the keratoconus, not with the stabilized keratoconus, patient with the advancing keratoconus, even we cannot do LASIK in thin corneas. So these are the indications for phakic lens. Nowadays, this indication has been changing also. Now we are doing with a low myopia also, but most of us been still doing for very high myopia, thin corneas, dry eyes, stabilized central keratoconus. Even you can do phakic lenses in post-RK patient and post-PK patient. These are the few contraindications. This everybody should remember. One is progressive refractory error. So keep taking the proper history, and there is a stabilization of the refractory error for a minimum period of 1 year. Rule out history of uveitis, glaucoma. But most important, antechamber less than 2.8. Never try this. And patient with the nuclear sclerosis, those are already developing cataract. You have got a better option like a IOL based option. Then, very important, personal or family history of retinal detachment. That is so important. I think you need to look into that, and of course, pregnancy. So, these are the advantage of any of this posterior chamber phakic IOL. Basically, it is far from the endothelium, excellent cosmosis, but the most important point I want to tell, these lenses are placed close to the nodal point of the eye. Because of this, I think patient will have a very good vision, and make sure that stable location, and it will not alter the shape of the cornea, and also completely reversible procedure. So these are the type of posterior chamber phakic lenses available in India. We have got, I think, from Star, we have got from Biotech, we have from, I think, from IOCare, and also from Appasamy. So Star, of course, even though Star is a hydrophilic material column, but it is coated with the Colama. Then all other Indian manufacturers are from hydrophilic acrylic. So these are the A-list preoperative checklist for the patient. So subjective refraction, keratometry, antechamber depth, pachymetry, axial length and white to white diameter. So coming to the refraction. So if you ask me, all even though they are myopic patient, I think cycloplegic refraction is must. Should we overcorrect them? No. Those are already using the contact lens. Those are with the soft contact lens, better to discontinue for a period of 4 to 5 days. Those are using RGP lens for discontinue for 1 week. So always keratometry, true K versus sim K. So always most of the topographer will measure the keratometry. My question to all my friends, whether posterior curvature is important for Phakic lenses? No, it will not change the toricity of the IOL significantly. Those who are doing with the autorefractometer, make sure that it will be calibrated very well, even including optical biometry. So what is antechamber depth? So coming to antechamber depth, which is from the endothelium to the anterocapsule. So it should be minimum 2.8 millimeter. So you can measure either from the anter-segment OCT or off scan. All our equipment, Pentacam, IOL Master 7, all this equipment will measure the ACD. But those who are doing with the ultrasound, but please remember to deduct the Pachy value. So coming to the antechamber depth, always deep antechamber depth, shallow antechamber depth, that helps in determining the appropriate model. This is very, very important. Probably it is the only determinant which would prevent patient to getting a phakic IOL. Always it is better on the safer side. When the less, because we all know that lens thickness increases with the age, the ACD tend to reduce progressively. So this is a ACD comparison with the different equipment, because since it is a master class, I am going in depth of all this thing. If you see with the IOL Master 500, with the IOL Master 700, Lens Star, Oxcan, if you see here, AS scan, IOL Master 700 and also AS OCT, the results are comparable. So, the reading from AS OCT, IOL Master 700 considered to be the most precise and accurate for ACD. Coming to the white to white, probably I can say this is the most important step which has been for the successful of the procedure. What I do in clinic, I take 2 to 3 reading. I tell also my other co-consultant to take another 2 to 3 reading. We compare. Always, whenever there is a discrepancy, white to white can be confirmed with the other instrument also, and also with the reading in the other eye. Because we know that oversizing giving a higher vault, that could lead to glaucoma. Undersizing will give a lower vault, that could lead to anterocapsular cataract. So coming to the white to white measurement, which is the successful result. See, now I am just telling, this is our experience based on the 100 patients. See, if you see digital calipers and with the off scan, this considered to be the most precise one. So always I think sometimes some of the equipment you may not get a unreliable reading. But see, my question always, where we have to take? Outer limbus to outer limbus, or mid limbus to mid limbus, or clear cornea to clear cornea. So we used to 2 years before I used to take from clear cornea to clear cornea. But again I come back to now mid limbus to mid limbus. So always patient must be in a supine position under the microscope, with the speculum applied, and the white to white measured horizontally. Of course, this is my older say clear cornea to clear cornea using digital caliper, but I think we should do it from mid limbus to mid limbus. So always post-op, you should look for the increasing the intraocular pressure, and you should always look for the vault. So what should be the vault? The vault is the distance between the posterior surface of phakic lens and the anterior part of the anterocapsule. So what should be the optimum vault? It might be either from half a corneal thickness to the 1.5 corneal thickness. That means ideal vault varies between 250 to 750 microns. These are the possible complications you can see from phakic lenses. You may have a low vault, you may have a high vault, you may have a refractive surprise. The patient may come to you with an increased intraocular pressure. Sometimes there may be changes in the angle pathology, iris shafting and poor corneal healing. This is a small video. I think this video I have recorded almost around 12 years before when I started doing the study for this biotech phakic lenses. So I think nowadays most of us been practicing with the Callisto or any of the image guided system. But still, when we do comparison with my dear friend Patwardhan Itoric, this thing, all results are good. First, if you mark it on the OT table, then with the help of this gyroscope, you can mark, then make sure that you are putting in the proper direction. So always when you're doing, once you mark, then you take inside the OT, then wherever should be the desired axis, you can again mark the axis. Then do the parasynthesis, then fill the viscoelastic. So when you are doing the viscoelastic also, make sure that you will not be touching the antercapsule. Then compared to the star, that is the columnar lenses, you can use even forceps to pick the lens, take the cartridge. How you are loading the normal intraocular lens, you have to load it. Once you load with this will go through 2.8 quite easily. Go with a very small jerky movement. Make sure that you look for the hole on your left side. In star, always you should look for the hole on the right side. But here you should look for the leading haptic. That hole has to be there on the left side. Always for beginners, I always say that put it over the iris. Don't put like directly behind the iris. Put it over the iris. Then fill the antechamber with a good viscoelastic. Take the tucker. Always from the leading haptic through the parasynthesis, you tuck in underneath the iris. From the trailing haptic, I always use the main entry. Try to tuck underneath the iris. So whenever you feel that okay, it is collapsing, don't become panic. Put some amount of viscoelastic. But once you tuck both the haptic, always you should look for the round pupil. This is very, very important. So once you know that it is round pupil, that is perfect. Now after putting, you could be able to see, not less rotated, you could be able to see exactly in the toric marking, it is coinciding with the whatever the marking which is present in the phakic lens. You could be able to see it is perfect. The results are as comparable whenever you are using any image guided system. So, but visco removal is so important in phakic lens. Always I do it with the simple cannula. My one take home message, stay within antechamber for a period of 1 minute for visco removal. Make sure that when you are staying this one, whatever the visco is there behind the lens also, it will come up, or sometimes it may come through the center hole, so that your visco cleanup should be very, very good. These are the future of acrylic phakic lenses. Excellent visual outcome, easy to load. It has got a both central and peripheral hole, and in my entire last 500 patients, 500 plus patients, no chance of flip and rotation also. But the most important part of this phakic lens is their calculating system. So now you should always think about the phakic lens where it has got a very good calculator. So the calculator always should know how much is going to be the vault in the coming afterwards. See, always you should look for long term, especially for long term safety, efficacy data should be must, and the company should have a customer centric approach. So always that makes the difference. So I am again come back to the calculator of these phakic lenses. If you see, it has got all the feature. You can enter white to white from different instruments. See, if you see here, you can enter from manual, Opscan, Pentacam, Topologizer, IOL Master 705, or lens. See, some of them, my close friends still have all this equipment. You can enter the data and enter the data in rest of the world. They have got two options. One is rest of the world and European region. So you enter in the rest of the world. Then always it will take up whatever the instrument is, it will take up. For example, if you have the white to white measurement from digital caliper Pentacam, we can input this measurement by selecting the specific instrument. This is very, very important. Then this is the one important feature, that is the vault prediction. See, after entering all the data, it will tell with or without lens rise. So here if you see in this case, vault prediction, I think around 418 micron. This is what I always discuss with my brother Gaurav Luthra. He has done some of the studies with the vault prediction. See, now most of the, whatever the formula, whatever the Phakic lens you take, but make sure that that calculator will have a vault prediction, because that will give the most predictable result. See, suppose if user has entered the lens size value from the ASOCT, vault prediction will be even more accurate. That is very, very important. So this is our experience with the acryl Phakic patient, 300 patient, which has come for 4 years of follow-up. If you see here, spherical, mean cylinder and the spherical equivalent from 6 months, 1 year, 4 years is almost like it is maintaining in the same level. If you see that distribution of manifest spherical equivalent is almost same. The wow factor in Phakic lens, as I already said, that we put near to the nodal point of the eye, the results are fabulous. I think more than 90% of the patient had a wow factor. And a couple of patients, of course, will have an increase in the IOP, which can be controlled with the anti-glaucoma medication. This is the mean vault. If you can see for all these years, the vault remains same, almost around 500 in our patients. This is our experience with the Phakic toric for around 100 patients. The patient age is between 23 to 39 years. Again, come for 4 years of follow-up. See, if you see here, again, results from pre-op, so about the mean sphere, mean cylinder and spherical equivalent, even after 4 years also, the stability of the lens is perfect, there is no rotation. This is the pre-op astigmatism. If you see here, more than 48% of the patient, the cylinder is between 1.5 to 2 cylinder. But post-operative refractive astigmatism, if you see here, just 80% of the patient has got less than 0.25 astigmatism, something remarkable. I think more than 95% of the patient had a refractive astigmatism, which is less than 0.5 diopter in the 4 years. So coming to the rotation stability, 86% of the patient had less than 5 degree rotation, and all eyes had a less than 10 degree rotation, which is something unique with these lenses. This is just those who want to have a head-to-head comparison, what I have to do. First, vault prediction, I think we are having in acryl Phakic, I think Evo Vision, ICL, I think they it to come out, they're about to get there. Those lenses are also very good. About the flexibility, this lens does not try to open upside down, so less chances of, as I said, that optic getting scar, or if touched with the forceps, sharp instrument handling is easy. But in Evo Vision lens, we all know that it is extremely flexible. These are chances lens may open upside down in some of the case. Injection system, very easy loading. Little bit complicated loading in case of Evo Vision ICL, but here it go through 2.8 quite easily. And of course, the dioptric range is up to 25, and you can customize even with I have put done for even 12 cylinder astigmatism. Safety, I think patient achieving post-operated uncorrected visual acuity equal or near pre-operative best corrected visual acuity. The endothelial loss was almost minus 3.51 plus or minus 9.69 in the year of 4 years. The 8 patient had an initial rise in the intraocular pressure, which has been controlled by medication and equally stopped. Spherical equivalent within plus or 1.5 diopter in 100% of the patient. None of the patient actually developed cataract or iris deformation, and none of the patient really required IOL explantation too. So in conclusion, acryl Phakic IOLs are safe and effective for treating mild, moderate and high refractive error. It gives peace of mind when it comes to loading, implantation and predictable vault and visual outcome. Open access to vault prediction, very, very important. Most innovative calculator make it unique from others. Customer support, training support, zeal of biotech to make improvise this lens support system, make it distinguished from the market. So I thank again my dear brother Madhu for giving me this opportunity. Again, I am so sorry that I could not able to make it because of I have to attend one very important program at 4 o'clock. So that's why I am giving you online. I think thank you Madhavi Akka to chairing this session. Thank you.
Thank you very much, sir. Thank you very much.
Excellent presentation, Nantamma, Krishna Prasad. It was very good. I think you have vast experience in all types of Phakic IOLs, but I think you have a training center for biotech acryl lenses. I found a little bit difficulty in implanting these lenses. They didn't seem as smooth as the ICLs, but probably with experience. My experience with ICLs is far more compared to the others. So that's the only difficulty I faced. But the beauty I found in this was, as you're implanting, it goes to the sulcus. So without even you needing to, the leading haptics Just like our IOL implantation, it just goes very beautifully. That is one advantage. And the second one you have told now, vault prediction. I was not aware of this. So that's a real good thing. If we can really predict the vault, then our sizing also can be much far better.
Yeah.
So anybody else has any questions regarding Phakic IOLs to Dr. Krishna Prasad? So I think it was a very comprehensive presentation. Thank you so much.
Actually, I wanted to talk about smile and the cataract, but Madhu was very particular. Sir, you have to talk on Phakic only. So, and again, congratulations, Madhu, that I think Madhu can come and sit next to Madhavi so that I can see you also.
Yeah.
Madhu.
So two
one
brothers.
thing I just wanted to tell you that I think Madhu, that first of all, before election only, I am congratulating. I think 100% Madhu is going to become the member scientific of all India. The people like you has to come to our AS podium. You have been very good innovator. You have been helping the people. Very good, thorough, very good. This one, good-hearted man. I think also we need your expertise. You have done great job as a cornea and refractive person. Very good cataract surgeon. I think All India Ophthalmological Society, we really require you in our team. I think looking forward, I think before only congratulations, I'm telling you, we are always with you.
Thank you so much, sir. Thank you so much. We'll send your memento and Angavastram to you directly. Thank you, sir.
Thank you, brother. Thank you.
I request Nandakishore, sir, to felicitate the chairperson, Madhavi madam, before we go on to the last session, before lunch. And VVLN, sir, also to receive the memento for the APMC observership. Very strict observers.